I'm supposed to start the proceeding.
We are live, sir.
All right. So, good evening to everyone on this very wonderful day. It's a Friday evening, and here we are going to welcome to the Cataract Symposium, the West chapter of the AIOS. And we have a wonderful lineup of speakers and great topics to initiate a great discussion. So I'm sure they'll be learning and take home points for from every discussion and every presentation. Welcome to the Cataract Symposium, the West chapter. I think there's a reverb somewhere. So we have our speakers, Dr. Nikhil Gandhi, Dr. Sean, and Dr. Amit Mahajan, who will be speaking to us today. So, and my co-moderators, Dr. Namrata Sharma and Dr. Rajesh Sinha are ever busy as always. So I'm the only one out here right now. And of course, the chairpersons are equally busy, Dr. Lalit Verma and Dr. Harbans Lal. So let's kickstart the proceedings with Dr. Nikhil Gandhi. And I know Dr. Nikhil personally, and he is a phenomenal, very, very great surgeon from a wine-producing region of Maharashtra, Cluj. And I've been to his place. It's a palatial house he has, and his father and his whole family is very, very warm. And not to take away anything, Dr. Nikhil is a great surgeon himself, and I'm sure that there'll be great tips in his presentation, which is on Phaco parameters. Yes. Over to you, Dr. Nikhil.
Thank you, Saumil. It was wonderful to see you again. It's been a long time. Anyways, to my presentation. So my topic is Phaco parameters. I'm Dr. Nikhil Mahavir Gandhi. So my practice is based in a tier 3 town called Cluj, which is 160 kilometers from Pune. I practice with my father, who is a general ophthalmologist, and my younger brother, who is a vitreoretinal surgeon. Currently, I'm a cataract and refractive consultant, and I'm into practice for past almost 1 decade. So what has changed over the years? I would say that patients' expectations have been increased a lot. And we need to match those level of expectations. And what really we need to do is we need to keep up with the technology. We all do agree that cataract is the most commonest procedure being done in the ophthalmology. And cataract being, and Phaco machines being they keep on updating the Phaco technology. And we need to keep ourselves updated with the same. So if I had to compare myself, I would, we have to compare ourselves being a pilot, being on the chair and trying to take off and land properly. This is a photograph of an old cockpit, and as you can see, there are not much of a switches or parameter changes that you need to do in those days. Whereas in today's era, you can see that there is a drastic change in the switches and parameters, and they have included so many things for the safety of the flight. Similar way applies to the Phaco machine. Earlier days, we used to have very minimal changes that we need to do during the surgery, whereas nowadays there are n number of parameters that we need to take into consideration for the safety of our patients. So why should I know about the Phaco parameters, and how would it benefit my surgery? Will it make any difference in the surgical outcome? The answer is yes. So understanding the mechanical principles underlying the technology allows us to optimize machine settings and safety troubleshoot problems encountered during the surgery. All surgeons, regardless of the level of surgical expertise, will benefit from reviewing the fundamentals of the Phaco emulsification, including the fluidics and ultrasound power modulations. An accomplished surgeon can improve the safety and efficacy of the techniques, and novice surgeon will have a distinct advantage of mastering these skills. So today, I would be covering on the topics like irrigation aspiration system, aspiration flow rate, vacuum, followability, rise time, surge, Phaco power, and Phaco modes. I wouldn't be getting too much into what settings a surgeon should be making, because I feel that is very personal and that differs from individual person, patient, and the machine that they use. So coming to the first topic is irrigation aspiration system, that it would be into inflow and outflow. The inflow should the inflow should always be greater than the outflow. If the outflow is greater than the inflow, there is quite a possibility of anterior chamber getting collapsed and chances of posterior capsular rupture. The inflow, there is the only one source of inflow, the saline is BSS. The irrigation system is which maintains the intraocular pressure, maintains the fluid flow, and removes the particles, cools the handpiece, and anterior chamber is maintained without any collapse. The safe levels without stressing the zonules or lens iris diaphragm. And when should a surgeon raise the bottle height? To deepen the anterior chamber if the aspiration and vacuum levels cause the chamber shallowing, and when when to lower the bottle height, when you see there is a posterior capsular rupture during vitrectomy, in high myop patients where already the anterior chamber is quite deep, and also in subluxated lenses. As too much of deep, if you try to increase the height in these cases, the fluid would definitely shift behind the IOL, and there would be more of vitreous loss. So outflow is a flow equal to P into R4. So P where stands for Phaco probe, and R is the outflow tubing size and outflow Phaco needle size. So aspiration flow rate at which the fluid and nuclear particles are removed from the eye when the tip is not occluded. And this is directly proportional to the rotational speed of the pump head, which is controlled by the foot pedal. So when should you reduce the low flow rate should be maintained? When you see in soft cataracts, in shallow ACs, in positive pressure patients, in leaky wounds, and in cortex as removals. And high flow rate should be kept during the hard nucleuses. Coming to the vacuum part, which is the negative suction force created by the pump at the probe tip. And fallibility is the third and final maneuvering in scavenging and emulsifying the mobile nucleus fragments. Higher the vacuum increases the force with which the material is pulled through the tip, which reduces the energy that is really required. And they're coming to the rise time, the time taken by the system to reach maximum vacuum setting once occlusion takes place. So in peristaltic machines, slow rise time, good safety margin, and the rise time can be decreased by increasing the flow rate. Whereas in Venturi system, there is rapid rise in time due to high flow rate. I do use both the machines. I do have a machine which uses peristaltic pump, and another is a Venturi. And when I used to use the Venturi in the initial days, I was not that confident, and the vacuum used to get built so fast that I used to get, even though the surgical time is reduced with the Venturi system, but I would definitely prefer a peristaltic machine over Venturi system. Coming to the surge, which occurs as occlusion breaks and the fluid from the anterior chamber rushes through the tip, which leads to the posterior capsular rupture, which I have seen myself whenever I used to have a high vacuum kept in the settings. So the ways to reduce the surge is by the surgeon and by the machine. By the surgeon, you decrease the effective flow rate, increase infusion, and use the AC maintainer, proper wound construction, and foot control. And by machine is by venting. Coming to the Phaco power, the ability of the Phaco handpiece to cut or emulsify the cataract, and which is directly related to the frequency, stroke length, and efficiency of the handpiece. Frequency is the number of backward and forward movements of the Phaco tip in unit time. Typical frequency is of 40 kilohertz. It might range from 27 to 60 kilohertz. And higher the frequency, more power and more heat is generated. Whereas low frequency, low power, and which is pretty safe in few patients. So stroke length is maximum width of the movement along the longitudinal axis of the tip. So the Phaco power delivery can be made as a non-linear or panel mode, where the preset power on entering the foot pedal position 3, whereas the linear Phaco is the gradual rise in parameters from 0 to preset with a linear relation to the foot pedal control. Nowadays, as I have evolved as a surgeon, I've tried to understand my machine, and I would definitely say by understanding the Phaco parameters and by modifying the parameters, you would definitely enjoy the surgery much more as compared to the previous days where I used to use I used to perform the Phaco just by the given set parameters by the company or which used to come along with the machine. So there is something called pulse mode, which gives the intermittent burst of Phaco at preset intervals of pulse per second. And burst mode, maximum power is delivered at intervals which vary with amount you depress the pedal. Maximum Phaco power, or you can say continuous mode, where the present preset by the surgeon, maximum ultrasound energy is obtained by actual Phaco power. So Phaco modes, I have seen few surgical videos online, and as I've seen, live surgeries, few surgeons, they directly go for the chop mode and they just cut it and emulsify the nucleus. I would definitely say that there are modes, we need to utilize it, like the sculpt mode, which is really for scraping of the nucleus, and you really don't want the nucleus to be drawn to the tip. So you should use low vacuum, low aspiration, but as much as power as you need longitudinally. Unlike torsional or transverse, which will likely draw the nucleus towards the tip. The chop mode is for holding the lens. This requires more of vacuum, more of aspiration, depending on the nucleus consistency. And the power is employed to drill the hole to begin the chopping. The torsional or transverse modes are less likely to repel the nucleus particles. Thus, they hold the nucleus in a proper way and emulsify it. So are there any other approaches to increase the efficiency? So limiting the power to prevent excessive heat buildup, to use the innovations in Phaco technology that augment the longitudinal Phaco when indicated. These innovations enable us to deliver power through lateral and rotational movements in two modes known as transversal and torsional ultrasound. So transversal ultrasound helps to emulsify the nucleus more than one direction by increasing the cutting efficiency. And the main advantage of torsional Phaco is increased energy efficiency, but the main disadvantage is significant tip movement. The transverse and torsional Phacos are proprietaries. That is, the transversal ultrasound is employed by the Johnson & Johnson Vision in White Star Signature Pro, and torsional ultrasound or OZIL is found in Alcon machines like Infinity and Centurion Vision System. So I would say less is more. Every cataract knows how to perform a cataract Phaco surgery. However, when it comes to specifics of making the adjustments to the settings on the machine, surgeons typically set up the parameters when they initially buy a new Phaco machine. Thus, because the machine and the surgeons are so good, many surgeons don't necessarily feel the need to make any changes from that point on. To get the most out of Phaco, following the basic principles of less is more, that is what I would definitely offer. So what are the benefits of changing the Phaco machine parameters, or what are the benefits of knowing your own machine is adequate energy is utilized, maintaining the anterior intraocular stability throughout the surgery. And remember that the primary goal during the cataract surgery is to perform nuclear disassembly and efficiently using just the right amount of Phaco energy. So thank you.
Thank you, Nikhil. That was definitely a very, very informative talk. And you introduced lots of concepts out there. And for a novice, for a beginner Phaco surgeon to grasp all these concepts will take time. So I would suggest you go back to the YouTube video, which is going to be there, and go through his presentation slowly, step by step and slide by slide again, in order for you to grasp the concept. So having said that, see, Nikhil, so you did touch upon these things, but let's just discuss, Dr. Sean, what would you think about your parameters for a normal nuclear sclerosis grade 1 to 2, which probably the beginning surgeons will encounter most in their practice?
Right. Actually, my Phaco power is very less, and even only thing is that I use the mode which I use is very less. Recently, I bought Centurion, so the Centurion parameters, as he said, that you don't want to change, but I used to change because each and every grade is different and each and every cataract is different. So my parameters are always less in grade 1 and 2, but if in case in high, so I have to increase the power also and this thing also. So these are the
very well said.
Yes.
Absolutely right, Dr. Sean.
Yes.
So Dr. Abhay Vasada always propagated the concept of less parameters,
Right.
slow motion, Phaco, emulsification, even Dr. Bob Asher. So we have to go by these principles in order to efficiently go through our surgery. That's what it and what Dr. Nikhil said very truly is when do we increase and decrease the bottle height? Now, one uh, situation is when things are not going all right, and say for example the iris is prolapsing out. So at that time, what is your concept? I would ask the entire panel generally: should we increase the bottle height? Should we decrease the bottle height?
Definitely have
Dr.
to
Nikhil.
decrease the bottle height, definitely.
Yeah,
Once the,
that also one more thing. It depends on like what are your side ports, like incisions. Like if the incisions are quite good, and if you can see, if you increase the bottle height, if deepening of the iris is there, then you can stay on the same bottle height. But if sometimes that leakage is there, then you have to reduce the bottle height. So this is my personal experience about
Absolutely.
it. Yes.
Right. Yes. We're talking about Phaco parameters and Phaco settings. So decreasing the bottle height generally and keeping the bottle at the lowest height, which is feasible for the surgery to take place, is always a good idea. In case of iris prolapse, also you have to decrease the bottle height. In general, if your Phaco is going on all right, still at lower parameters of lower bottle height, studies have shown that there is decreased turbulence inside the anterior chamber, and that helps to preserve the corneal endothelial integrity.
Right.
yeah.
Right.
And
So that is about the bottle height.
and
Yes.
also less dispersion of the pigments that have been released due to the sudden deepening and shallowing of the anterior chamber. Once if you are if you have a this thing of keeping the bottle height on the higher side, and you tend to have the deepening of the anterior chamber, and once you try to remove the probe, there is shallowing of the anterior chamber. By this you might have a release of the pigments, and then later on you might land up into CME also in post-op patients. So, having a adequate bottle height would definitely benefit our post-op outcomes. That is what I feel.
Correct. Absolutely right. And then the other parameters are about the fluidics, that is the aspiration flow rate and the vacuum settings. Now, again, just to go step by step, I'm talking about a conventional Phaco system, Dr. Nikhil, is that when it's just a longitudinal, there's no torsional, there's no ellipse. I'm just talking about longitudinal Phaco. In step one, I'm talking about for the sake of beginners.
Mm-hmm.
When you're in sculpting mode, what would be typically your parameters? I'm talking about aspiration flow rate. What would be the aspiration flow rate typically?
So what I would keep is aspiration flow rate would be around 28, and the vacuum around 170. And I would definitely put my energy levels on, like, if it is grade 2 and 3, which we often see in my practice, I would keep it around 20 or 30. But if I'm using a proper Phaco machine, I'll definitely on the OZIL IP without any energy, like the energy of 0 and the OZIL IP on, with the amplitude set on 70 with a linear rise in the energy of layer.
So just to put it very simply again, the Phaco would be according to the grade of cataract, say for example around 60 to 70% of power. The vacuum settings would be around 150 to 180 millimeters of mercury, and the aspiration flow rate would be anything between 15, 20, 25 cc's per minute. Am I correct?
Yes.
Lovely. So that is in sculpt mode.
Yeah, bottle height would be around 75, 70, 75, depending on the anterior chamber depth and what is the, whether the patient is myopic or not, whether
Sure.
it is normal.
So moving on from sculpting to quadrant manipulation. So you've sculpted, you've cracked. Now you want to just eat up in your pieces which you made. So then, what would be the typical parameters?
So my bottle height would remain the same, around 75. The vacuum will go around 380 to 400, and the amplitude would shift from 70 to 80, and I will still not put an active energy. Just the IP OZIL IP will be on. and the aspiration will be around 35 to 38. So
essentially, if I get it correctly, the Phaco power will be more or less the same, or you might increase it a little bit.
Power, I will keep it the same, but I would try to increase the amplitude.
Sure.
Yeah.
Fair enough. And the vacuum is the one which will actually go up.
Yeah,
right.
That depends on the grade of cataract. Like if you are using,
absolutely.
if the grade is higher, you can go with more vacuum. This is my personal.
Correct.
Even though
Correct. Absolutely.
because sometimes if you are having good vacuum, it is very easy for you to catch the cataract and sorry, the nucleus, and that fragment will be more easy. This is my experience that grade, if it is more than grade 2, then go for higher vacuum, like what we are
Dr.
using.
Amit, in quadrant aspiration.
No, I think I will divide my parameters for two different things. One is a chop and another one is a fragment removal. For chop, I always keep vacuum slightly on the higher side, but while fragment removal, I will keep the vacuum slightly on the lower side, as well as the flow rate also on slightly lower side. See, now there are two different theories or two different types. In fragment removal, what Dr. Abhay Basavada is doing, like everything is very low. He's keeping like AFR say 25 or 28 only, and vacuum slightly higher, 400, 450 like that. And power depending upon the grade of the nucleus is the one theory, which I also enjoy a lot. And the second one is slightly faster surgery, like what Dr. Uday Devgan does, where he keeps AFR like 35 or even up to the 40 also, which slightly speed up the fragment removal. So in some cases, I may prefer for a higher AFR, which slightly make my surgery faster. But in vacuum, in a chop, vacuum will be more, power will be slightly less. And in fragment removal, I will increase AFR and reduce the vacuum.
Okay. So for a typical beginner surgeon who is practicing 4-quadrant, that is the whole premise of the whole discussion right now. So we have to cater to that initially first. So we want simple tips for them to take home from at the end of the whole discussion. What should be the take home tip is what we are talking about.
Yes.
Correct?
Yes.
Absolutely. So wonderful. And there was we spoke about AFR, we spoke about vacuum, we spoke about bottle height, and yes. So essentially, we are talking about these. Why is it important for us to know? Is what Dr. Nikhil said. Is it's very important to just know your machine so that you have the best capabilities to get out of that machine, so that you can do the best job for your surgery, for your patient. Yeah. Am I correct? Yes. Is there anything to add by our panelists?
I just want to add one point that one has to look for the leakages also. Yeah, wound leak also, from side port, from main port also. If there is a leakage, and if there is a significant leakage, then again we have to change all the parameters.
So absolutely. As I said in between, so wound leakage also matters a lot. So, if the wound is not constructed well, or it is more than the size of your sleeve, then of course you have to raise the bottle height and reduce the vacuum, and all the parameters needs to be changed. But then that is altogether a different scenario actually. But yes, of course, you have pointed out rightly. So we need to manage the wound leakage also. We need to take into consideration that as well.
So also for beginner surgeons, I would suggest the use of this pulse mode, which are there in all machines today, and they help decrease the effective absolute phaco power and delivery into the eye. And the pulse mode is where there is a pulses, as Dr. Nikhil had explained, of energy of short energy which is given. So that is a useful tip for beginner surgeons.
I have seen Dr. Akahoshi, when I was with him, he used to use the burst mode, and he used to enjoy his surgery with the burst mode itself. But somehow that is not good in my hands. I feel that it differs from surgeon to surgeon, and I feel whichever suits your practice and your patient would definitely. Every surgeon should have an feel of pulse mode, continuous, and burst mode, and then they should come to a conclusion what they really want to use it, which mode they will
Absolutely. Absolutely. For most of us, we will not be finishing our cataract surgery like what Dr. Akashi would do in 3 minutes or 2 minutes for his entire cataract surgery, incision to incision. So yes, we have to know what is best in our hands. So thank you, Dr. Nikhil. That was really indeed very nice and very informative. Shall we go on to the next speaker, Dr. Sean?
Yeah. Sean.
Perfect. Lovely.
Yes. I'm here only. Yes.
Excellent.
Sorry. Yes.
So yes, Dr. Sean, he's the director at Chinchole Eye Hospital at Buldana, and he will be speaking about a very practical topic about small pupil cataract surgery. So very often in our surgical cases, even though the pupil may be dilated initially, it tends to sometimes because of our handling, it tends to become small. Or sometimes even preoperatively detect a patient having small pupil. So Dr. Sean will tell us in his expert comment, with his expert experience, or how to deal with a small pupil in cataract surgery. Dr. Sean.
Thank you, Samil, and good evening, everyone. And thank you, Allergan, for giving me this chance of presenting a small pupil cataract surgery. My slides are there. Can you see? Hello. Yes. Okay. Dealing with small pupil. 1 minute. I will just. These are the common causes for small pupil, that is advanced age, post-uveitis, cataract surgery that leads to posterior synechia, pseudo-exclusion syndrome, diabetic patient, floppy iris syndrome, high hypermetropia, prolonged myotic therapy, and neurological conditions. What problem occurs during surgery, that is during capsular axis, it's difficult to visualization of axis margin, that leading to ill judgment of size, shape, and if any extension, that leads to peripheral damage also. In hydro procedures, there are always difficulty, that inability to judge the correct dissection plane, leading to difficulty in rotation of the nucleus, and that leads to sometimes nucleus drop or iris tissue damage, sometimes tears to the axis also. During phaco emulsification, even though we can try out everything, then during phaco the smaller the pupil, the poorer will be the red reflex, which leads to difficulty in judging the depth, and that leads to difficulty in stretching, that leads to PC tear, and the whole surgery will be difficult to do. Risk of catching pupillary margin with phaco tip, it's more dangerous. In advent, capsule catch or capsular trauma with chopper can cause posterior tear and extension to PC risk. Difficulty in cortical aspiration and implantation of IOL. What are the consequences? That leads to iris bleeding, increased risk of iris damage, iris prolapse from the wounds, smaller the axis, that again difficult for red reflex and everything. Incomplete evacuation of cortical matter, problem ensuing in IOL implantation. Difficulty with poor alignment of toric IOLs also. These are we should preoperative, we should think of it that there is my long-term use of myotics, pseudo-exclusion syndrome is there, neurological disorders, uveitis, angular closure glaucoma, trauma, any previous history of surgery, and is there any treatment or any treatment going on for prostate or for urinary incompetency and all. So management is there with the posterior synechia can be managed by mitratic, subconjugal injections of mitracane. If patient is using myotic, asked to discontinue for 3 weeks before surgery. How to go ahead to do small pupil cataract surgery? It depends on you, that is surgical technique. Pupil expansion devices are there, depend on pupil size and biomechanical properties of iris. What is small? Like, is it 2 millimeter, 3 millimeter, or 4 millimeter? That depends. The pupillar size directly relative to surgical skill and technique and intraoperative situation and iris tissue property. This is my surgical case where as did my small pupil cataract surgery. This is at least 3 millimeter of pupillary size. Here I can go with good OVD. First I use refined blues to stain the anterior capsule. With the help of good OVD, I can deepen the chamber and there is little bit stretching of pupil also. Here I can do my CCC with good hydrodissection and hydrodelineation. I can manage because I can see with the CC, I can see the pupillary margin also and CCC also with hydrodissection plane. So here I had done the hydrodissection, hydrodelineation, but somehow I can see there is a size is getting smaller, the pupil is getting constricted. But still I manage with OVD. Again, I started here. I use OVD because with a good OVD, you can continue your surgery. Each and every step is more important. As you can see, as Nikhil said, he decreased the fluid parameters. Here also I can use that. But each and after trenching also or direct chop technique, each and every nucleus, I used to bring it in the center in the pupillary margin, and then only I used to quadrant I used to eat. Or this is more important. Why? Because sometimes with the Phaco probe we can again damage to the iris tissue, and that leads to pupillary construction. So why I am using bimanual? This is also more important in this case. Bimanual use is more important because you will get two hands to use. If you will use single one, there are chances of iris touch or iris damage. And here also you can see there is iris trauma is there, and that leads to small pupil, but somehow I can manage with this size. And see, you can see now the size of pupil, but still with bimanual I can have that feel, and I can see the braid reflex also. And this is my surgery without using any devices. This is the case of phacolytic glaucoma, and patient was having arthritis. So I was in my mind that there was something that leads to small pupil. So again the same procedure, but here what I have done with good viscoelastic. Before going to viscoelastic, I did posterior synochialysis, like breaking of posterior synechia with iris spatula. That will help me to stretch the pupillary margin. Again with the side port incision with two instruments, like one is Y hook and one is blunt. Either I can use one blunt chopper, or with the hook again, I can stretch the pupil. And as you can see, there is little bit stretching of pupil margin, but I can see there is a fragment, or there is no, sorry, there is not a fragment. There is a exudative membrane which forms the pupillary constriction. So I break with the side port scissor, and with the use of BHEX, I can continue my surgery. This is a stepwise approach towards pupillary expansion. Actually, this is very simple, but somehow I don't find this is that much important or that much helpful, because somehow, even though I can use this pupillary stretching, that again leads to pupillary constriction, and I cannot continue with the same case. This is with the spatula, I break the posterior synechia, and this is with the Y hooks. I can stretch both horizontally and vertically, but don't find that much helpful. So after that, even though the stretch pupilloplasty technique, I have to use pupillary expansion devices. This is synochialysis. Sometimes you can find while doing surgery, you can find that this is now good, good pupillary margin is there, or I can see good view is there, but still we need some synochialysis or some small cut at the pupillary margin that will help you to see the CCC, which will help after staining also, and I can continue with my surgery. This is sometimes if you want to extend your surgery, if you are not planning for Phaco surgery and suddenly you want to do SICS, so this thing will help you. This is a good device. This is again the same case, iridocyclitis. I did staining after that with the posterior synechia breakage with iris spatula. I tried to do that. Again, I can see with the two side port incision with stretch pupilloplasty. I tried stretch pupilloplasty, but somehow I can see there is exudative membrane on the anterior face, that is iris tissue is still attached. So with the side port scissor, I can do the cutting or break the synechia in between. But still I don't find that much is helpful with the stretching of the pupil. Here I can try it, but that won't help. Even I tried with the Werner scissor. Again, the same problem. I don't find that, I'm not happy with the pupillary size. So with the parasynthesis incision, I went for iris hook. For the beginning, it was very difficult for me also to put the iris hook, because whenever I used to put that was going to slip from my hands. So I saw so many YouTube channel and all. Then I learned how to put the iris hook. There should be minimum 4 to 5 iris hook incision. I usually put 4 incision. That will give me a quadrant shape. But the 5th one is more important, that if your Phaco probe is there, behind the Phaco probe, you should put 1/5 one iris hook, so that whenever you are going to put the Phaco probe inside, your iris catch should not be there. So if you are not comfortable with the 4th one, you can go ahead with the 5th one. And here again the same procedure, bring all the nucleus in the center, and you can do your surgery very well. And it is also more important to know, whenever you are putting the iris hook, to remove the iris hook is also that much difficult, because that may leads to iris trauma. Again, the bleeding will start, or there may be chances of IRIT, CME in the post-operative phase. So removing is also that much important. After removing, make it sure that there should not be iris trauma. Only thing is that when you are introducing the iris hook, there are chances of shallow anterior chamber. These are some pupil expansion devices in the market available. But as I'm using BHEX pupil expander, because I find it very easy. In the beginning, the same problem was there with me also. Before using, I used to put Trifine Blue to stain the anterior capsule. Before breakage of posterior synechia, I used to stain, because sometimes you may find there are chances of pseudo exclusion. Sometimes there is zonal damage that you can see, so that you can how to extend the cataract surgery, or how to change the cataract surgical scenario, that you can help it. Sometimes you can use it with the forceps, but directly I can use with the forceps also. And BHEX is very simple. Actually, there are flanges and notches. Bring it into the anterior chamber first. After bringing into the anterior chamber, make it sure that your notches should be at perpendicular to each other, and you can get a good hexagonal shape. Don't hesitate to bring it again. If sometimes the notches get behind the iris, just bring it out, and again you can start putting, because sometimes so many things have happened, accident had happened because of the BHEX, that BHEX had gone behind the iris, and it was difficult to remove, and again you have to change the your surgical system. So these are the good hexagonal shape, easy to remove, direct pull and push technique. You can use a side port forceps, which is available in the market, and you can easily remove the BHEX pupil expander. And it is easy to remove, and to insert also needs some good technical mind in your skill. Gupta pupil expander, I used to have this before, because this is very easy to insert. You can get it with the injector and cartridge. It gives you a square shape, but that angle of the square shape should be towards your main port incision, because sometimes if your shape is different, that may cause a catch while doing the Phaco surgery, and that leads to iris damage, and again the iris tissue breakage will be there, tear will be there, bleeding will be there, and hazy cornea will start. So this is more important to know the how to put the Gupta pupil expander also. As Sumil said, that intraoperative meiosis, these are the more common nowadays, because when you are using Phaco and when you are in a hurry, sometimes you may catch the pupil and see here, I had done that, my pupil got constricted. So now commercially available, before it was not available. So they used to give me as a sample, but now it is commercial available. Injection tropicamide, phenylephrine and lignocaine. You can see after constriction and after using the intracameral, I can go ahead with my surgical this thing. I can see even the CCC margin with good. This is a multifocal lens which I put. Advantage of iris hook over the pupil expander is, that you can know. Technically much easier to insert and remove. Pupil expander is difficult to insert after capsular access. This is more important. But iris hook is more reliable in such cases. And now the advantage of pupil expander over iris hook is no need for any paracentesis, extra paracentesis incision. Easy fixation points are there because there are notches, there are holes, there are flanges. And with the side port forceps, you can use it very nicely. Smooth edges are there and less trauma to iris tissues and easy flexibility. It will be more easy because it won't give any shallow anterior chamber. But only thing is that while inserting, you should know how to fix it, because so many times, sometimes you can't see the holes. Even while removing, sometimes that holes will help you just to put iris nucleus dialer, and you can bring it into the anterior chamber, and normally you can pull it outside. So this is the advantage of pupil expander over iris hook. Thank you very much.
Lovely presentation, Dr. Sean.
Yeah, thank you.
And full of practical points. So I'll be, of course, slightly in our discussion, summarizing the points which Dr. Sean also said, re-emphasizing the points. But what is your approach, Dr. Nikhil, to small people? So as he has rightly said, that I will first definitely use a chondroitin sulfate along with sodium hyaluronate proper viscose, so as to make the anterior chamber quite deep, so as I can maneuver it during the procedure. If I want to, I will try to stretch the pupil. If it is not possible, definitely I'll go for the BX expansion ring, and or else I'll definitely, I used to use the iris hooks, but nowadays, as a, I've stopped using it because it's quite painful to remove them, and making extra additional 4 ports is not at all that feasible, and it's quite time consuming as well. So I feel that, and nowadays, as you are getting the phenocaine that is like commercially available, lignocaine with phenylephrine, I seriously don't feel anything like I need to do anything extra to expand the pupil. But these are the few points that you need to use a proper visco, a quality visco, to deepen the anterior chamber, because you are continuously stretching the pupil. You want to stretch the pupil, but I think that we need to highlight on what happens post-operatively. Is there anything additional drugs that you need to add into these patients? Because even that matters a lot. Because what I have seen is most of the patients, they will have a fibrinous uveitis or fibrinous membranes, and then you need to start them on the oral steroids on the first day itself. What is your take, sir? Like, so the thing is, in my hands, the small pupil outcome is quite, I would say, almost equally quiet as compared to a normal otherwise situation. So I have very rarely had the need to start patients on oral steroids, as you said, but to each their own, I guess. And Dr. Amit, I would invite your suggestions or views also on the matter.
Yes, excellent presentation, Dr. Sean. He has covered almost all the points, but just I want to highlight 3 points here. My first point is, before starting surgery, one should be mentally prepared that what he is going to operate. Don't shout on your assistants or OT assistant that "Arey, iska to pupil dilate nahi hua hai." You should be mentally prepared what you are dealing with. You should be knowing exactly what will be your strategy. Either you are going to use BHEX or any pupil expanding other devices, hooks, or you are not going to use anything. So your mental idea should be clear before starting the surgery. Second thing here, I would like to adapt MS Dhoni approach. Like, don't think of final outcome. Never think of final outcome. Just go step by step. Step by step, just step by step. Just now, just before starting the surgery, you just think of using any device. Secondly, focus on the rhexis. First, try to make a good rhexis. After rhexis, then hydro, focus on the hydro, nucleus rotation. After that, while nucleus management in small pupil, I don't want any fancy items like direct chop or like anything. I don't want here anything fine. I just want to go by very basic, just do a central, deep, long trench as far as possible and divide the nucleus into two pieces. Once your nucleus is cracked in two pieces, you have won half of your war, because then dividing it in short is another way. Very easily you can chop it in a small pieces. But if your posterior plate is not cracked, you are in a big trouble. So whenever in a small pupil case scenario, just try to make a single central deep trench and divide it into two heminucleus. And what I said by Dhoni approach is just focus on that step only. Don't think of final step. What will be the patient vision or like that? Just go step by step. And third point here I want to add is regarding the phenocan. Phenocan is an excellent drug, but I just want to tell everybody that it is not going to dilate a non-dilating pupil. But still, then also we have to use the phenocan as it prevents intraoperative meiosis. So suppose if at the beginning your pupil is 4 millimeter, you start the surgery without using phenocan, pupil may go down to 2 millimeter or like that also. But if you use the phenocan, it will remain as it is, what was the preoperative. So phenocan won't dilate the pupil, but it will prevent intraoperative meiosis.
I need to add one more thing. Like phenocan, we inject phenocan not just to keep the pupil dilated or prevent it from meiosis, but also to anesthetize the iris, because you are going to handle the iris a lot, and I feel the patient is going to have lots of pain and he's going to grumble, and there are so many things that he's not going to cooperate, because most of us we operate under topical, so the patient won't be comfortable and he won't let you do the surgery.
Absolutely.
That is another benefit of using the phenocan. And so I want to ask all three of you, like, in which cases do you see small pupils? Like, is it the most of your cases like post uveitic patients, or is it the PXF pupils, or in which cases mostly you encounter these patients? Like, what patients do you have?
So yes, go ahead, Dr.
No, please. I will talk later. Yeah.
Most of the times, if at all, if they are diabetic, sometimes they have non-dilating pupils. And also PXF is one of the situations, but PXF is not as common in my practice as diabetic patients in general. So that's the number one. If it's a non-diabetic, if it's a diabetic and a non-dilating pupil, I'll be prepared for it. Also, sometimes there's intraoperative meiosis, and very commonly, you've not really done anything much. You've not touched the iris, but sometimes it's just the turbulence of the fluid inside the anterior chamber which causes the meiosis of the pupil. So we have to be ready, as Dr. Amit said, for any such situation which may arise at that time. And go ahead and calmly go ahead with what strategy and what plan should be there for our patients.
Yeah, I will just add in that. Just I said that your preoperative workup should be proper. My second slide was on that one. Because because you can see in the OPD also that this is a small pupil, this is not going to dilate. Even after dilating for half an hour, 1 hour, he is sitting in the OPD and the pupil, the sister or your assistant will tell that the sir, pupil dilate nahi ho raha, it is like that only. So you preoperative only you will come to know. So there should not be that much panic. It's not like you are not sick, because when cataract is there, at least preoperative workup is there for IL, for you can see for biometry or for anything. But what the last point which I asked, that ask him for any medicine, because if he is a male and if he is diabetic, even though he is a diabetic, you can see there is small dilatation. But even if with the dilatation, you should ask him, are you taking any prostate treatment or any urinary incompetence? Because our side, there are so many urologists are prescribing Tamsuline. So that leads to constriction of the pupil, because it's not going to dilate anyhow. And by chance, if you ask the patient like what are the tablets are going on, is there any other problem you have, definitely you will come to know, because I had operated so many cases and they are giving the same history that we have urinary incompetence and we take this tablet for urinary. And whenever, if your physician is very close to you, or the nephrologist is very close to you, and if you think that he's going to he's going to send or refer patient to you for cataract surgery, ask him to stop that tablet, because even though they have started one tablet, that is going to hamper on your iris, and definitely that will give you a big problem. So preoperative workup, as Amit said, as you said, Samil, you don't get that much time, because we are in that area where arthritis is there, low socio-economical status are there, low care is there, everything is there, and we used to get such type of cataract very routinely. So rather doing we should give, we want that we should give them best of the best. So these are the problem, and so pre-op workout is more important in such cases, because if you will come to know that this is the surgery, so I used to keep this surgery in the last, because we know that sometimes so many things are going to happen, and Amit said anything can happen, you should be ready for that. It's not like you have planned, and so many things are there. These patients are coming from other hospital also, because they don't want to operate on a small pupil cataract surgery. And this is the fact that you should take care of this patient and you should explain them. And I used to explain while drawing only कि भाई तुम्हारा pupil इतना dilate नहीं होता है, you don't find this much is there, and we have to do this type of surgery. Even though patient want SICS also or Phaco also, the scenario will be same. Only thing is that if you are going to do Phaco surgery, explain them, anything can happen. And this is a good thing Amit said. This is now the surgical part which I am going to talk. That he said crack, that is more important. As I said, Amit, you should go in the center and crack the nucleus and bring, after doing the quadrants, bring the nucleus into the center. If you will bring into the center, there will be deepening of the chamber also, and there will not be any problem of iris catch also or iris trauma also. But even though if there are chances with the second hand, we have chopper in our hand, there are some chances to iris damage or iris touch, and that leads to meiosis in between. So, but again, you can manage it by, as I said, you can increase the bottle height also. Sometimes that bottle height, and if your side ports are proper, then even though you will increase the bottle height, you will get the deepening of the chamber and little bit straightening of the pupil. It's not that much helpful, but at least definitely there will be a straightening of the pupillary margin, and that pupillary margin straightening will at least help you to bring the nucleus into the center, and you can have that nucleus fragment very nicely, and you can go ahead for the rest.
That's a point which you said about bottle height and a small pupil.
Yeah.
Slightly controversial, I would think, whether to increase it or decrease it. Well, there's no foolproof way of going about it. Sometimes increasing it, as you said, may stretch the pupil, but I also find that also the turbulence created by increasing the bottle height also causes meiosis. So I would not actively suggest increasing the bottle height in all situations. We have to assess and see. So just to summarize a little bit about small pupil cataract surgery, my whole concept of small pupil cataract surgery changed upside down with a very simple sentence by Dr. Abhay Vasavada, in which he says, what is the issue with small pupil? You're anyway supposed to remain in the center. Your Phaco probe is anyway supposed to remain in the center of the eye. The small pupil just forces you to do so. So that really got me thinking, saying that yes, small pupil is not that bad. It just makes me to keep my Phaco probe right in the center where it's supposed to be. Having said that, there are problems with visualization, as you rightly said, Dr. Sean. And the ways about going it is preoperative. any take on anybody does those the epinephrine in saline bottles, saline infusion bottles anymore? I guess not. That used to be done previously, but I would not actively recommend that as well because of the fact that we have good armamentarium these days in the form of pupil expanders and hooks. So in everybody's OT, we should have as a backup these hooks, which or pupil expanders. The hooks come in a set of 5 hooks, but using 4 hooks is good enough. You can use it as a square configuration. Square is let me draw it this way, in which your hooks are straddling your main port, and or you can have it as a diamond configuration where the hooks are behind your main port. Diamond configuration is slightly more difficult to achieve, but it's better. You should aim for that because you get a long axis diagonal, which you can which is unobstructed. Also, as Dr. Sean rightly said, the iris does not impinge on the Phaco probe while you're going in and out, so that helps. Also, there are beautiful pupil expanders like the Malugan ring and the BHEX ring. And as also talked about the Midriatix, that is the Phenocane Plus, and also the T Plus Ultra, which are commonly available these days, which we should be using to help in our small pupil cataract surgery. Also, keep in mind the post-operative regime. If required, step up the steroids, increase the anti-inflammatories, Nipafenac or Bromfenac, as you may use, to help prevent CME, which is very common in these situations. So beautiful talk, Dr. Sean. And let's go ahead with the third and final presentation by Dr. Amit Mahajan. He's a director of Om Netralay at Chalesgaon. And he's going to talk about no more trouble in posterior polar cataract surgery.
Good evening, everyone. At the outset, I would like to thank Allergan and AIOS for. Is my presentation is visible?
No, Dr. Amit, your slides are not visible. You can share your screen. While he shares his screen, we know that PPC is definitely an issue. And yeah, we got the screens up. Your slides are up, Dr. Amit, and you can carry on.
Yes. So, good evening, everyone. At the outset, I would like to thank AIOS and Allergan for giving me this opportunity. So, why these posterior polar cataracts are so special? So, as you all know, that it has been stated in various studies that the rate of complication in posterior polar cataract is almost up to 33%. This clearly means that 1 out of 4 or 5 cases is going to land up in a complications. Secondly, most of the patients having posterior polar cataracts, they are the young adults, like in between 25 to 45 of years. So naturally, their visual demands is more. And at the same time, their preoperative vision is also 6/24 or even better. Only the quality of vision is hampered because of this posterior polar cataract. So we need to deliver the best results. So what are the main issues in posterior polar phaco's? So there are 3 main issues. The first and the most is we cannot do the hydro. So as there is no hydro dissection, we cannot rotate the nucleus. So naturally nucleus management becomes difficult. Then the second one is either we do it with any method or anything, there is inherent weakness or inherent deficiency of the posterior capsule at the level of plaques. So there are high chances of PC rent and other complications. And the third is, even though you manage nucleus very well, then remaining epinuclears and cortex removal is also a very big issue as you have not done hydrodissection. So removing these epinucleus and cortex is also a big headache. So for the sake of surgery, I divide this posterior polar cataract into 2 categories. The one which is having very soft grade, like only grade 1 or grade 2 and having central plaques only. And the second one is the posterior plaque with a slightly harder nucleus like grade 2 or grade 3. So let's go one by one. So first we will see the how to manage posterior polar with slightly harder grade of nucleus.
As we all know that so many things have been said and done about the management of posterior polar cataract, but still the mystery continues. So in this video, I will be sharing a new technique of nucleus debulking in slightly harder grade of posterior polar cataract. The first and the most crucial step is properly size rhexis. It should be at least 5.5 mm, as a smaller rhexis may invite many surgical difficulties. 2.2 main wound is done. Now small clots of fluid injected in multiple quadrants, taking care that fluid wave should not cross the center. Now a small central deep trench is made as usual, and then without rotating the nucleus, using torsional Ozil power, horizontal trench is made exactly perpendicular to the original vertical trench so as to make a plus sign. But here we don't have to rotate the nucleus. We are using the torsional power to make this horizontal trench. Now, without rotation, nucleus is cracked in all the four quadrants from periphery to center without disturbing the central plaque. Here, the separation should be proper, gradual and sharp in all the four quadrants. You can take a multiple attempts, but separation should be proper from periphery towards the center and keep the central plaque attached as it is, so that now you have got four separate pieces attached centrally like a flower petals. Now you can easily hold the apex of the piece with the Phaco Pro and disengage with the chopper from the periphery easily and emulsify at the pupillary plane with very low parameters, like bottle height should be 50 to 60 mm, flow rate should be around 25 to 30, and a vacuum of about 250 or 300 is more than sufficient. That is what you require to emulsify these separated pieces in the center. Now after easily emulsifying these four pieces, you are left with a thick epinuclear sheet with cortex. So here I always prefer bimanual than the coaxial because it helps me in 360-degree removal. Here tip is to position your aspiration cannula exactly below the anterior capsule rim. Hold and occlude the cortical sheet, not the epinuclear plate. Swap it horizontally to loosen the adhesions, and then finally pull it in a posterior direction towards the central plaque up to the plaque. Repeat the same thing in all the 360 direction so that the cortex is loosened from the periphery, but keep it attached centrally. And in the last, finally, you can remove the central plaque very easily like a flower petal direction, so that first loose all the cortex from the periphery. Now always keep in mind to do the visco-fluid exchange. Before removing irrigation cannula, always fill the chamber with the visco to avoid unnecessary shallowing of the chamber. So to conclude, you must have at least 5.5 mm oval shape rhexis, no fluid wave crossing the center, very low parameter central trenching in both the direction, separation of all the quadrants from periphery but keep it attached centrally, visco fluid exchange, and bimanual eye in a flower petal type of fashion. Thank you.
So with this technique, with where the nucleus is slightly harder, I have managed 23 cases in which I had rent in 3 cases. That means the complication rate was almost 13%. Now, when coming to the soft PPC, as we all know that soft PPC, they are the more common bad PPCs. So here also the principle remains the same. The rhexis should be large, oval, at least there should be 5.5 mm rhexis. Not oval, if circular, then also okay, but not less than 5.5 mm rhexis, because we have to do lots of manipulations as we are not doing hydro. So smaller rhexis will invite a big troubles. So no baby rhexis, at least 5 to 5.5 mm rhexis, and it should be oval. Why I am emphasizing on oval? is, suppose even if rent is occurred, we can put that IOL over the horizontal one. Now you can see here the very small, gently hydro delineation I am doing, and very small, very gradual, and see, now the nucleus pops up. So that becomes very easy. When such type of nucleus pops up, the remaining case becomes very easy, very easy. But this is not the always, not always you are able to pop up the nucleus out of the bag. So while hydro delineation, one has to put a very small, gentle, little, small aliquots of the fluid all over the quadrant. And then there is a one technique of doing hydro delineation. You just have to pierce inside the nucleus and then withdraw your cannula slightly and then inject the fluid. So that will make a good wave all around the your nucleus, and it will get hydro delineated. So what I am emphasizing in this video is, now, as you can see, the nucleus is gone, but see how this epinucleus and cortex sheet, they are how sticky. So here the key is to go slow, steady, quiet, go all the 360-degree, hold the cortex, occlude the cortex, pull it posteriorly, swap horizontally, and at the same time keep the central plaque intact. That should be removed in the last moment, when you are sure that your all the epinuclear bag is 360-degree free. Once you are sure that your bag is 360-degree free, then at the last you can emulsify that central plaque. So I will show you one more video. See, again, in this video I will trying to show you demonstrate you one small complication, that it is not always easy to do the posterior polar cataract. As you can see, oval rhexis, hydro delineation, everything is going as per the rule, or as per the we have decided. Small gentle wave is going on, and see, this is hydro delineation is done. Here the key is to just I'm sorry. Here just key is to just go with inside the cortex with your cannula, then slightly remove it and then push the fluid. Again, I am making a central trench, then horizontal lateral sculpting. Everything is going smoothly. Lateral trenching is also done. See, everything is going smoothly as per decided the plan. Epinucleus, cortex, I am removing it gently. See, now epinucleus has gone, only cortex is remaining. See, this is the last piece of cortex, and this last piece of cortex is also has been aspirated. As you can see now, the PC is very intact and very clean and intact PC. So I was very happy that I have achieved everything, and now I am going to just planning to implant the IOL and see what is going to happen now. Out of the excitement that my PC is intact and I have done successful surgery, I forgot to fill the chamber with the visco, as I have not done that visco fluid exchange. And now see what is going to happen in the next moment. PC is intact. There is nothing wrong in this PC now. Now I am planning to put the IOL. So I have opened the cartridge and I am putting the visco and see what is going inside. See, the huge rent is going on, huge rent, and see how that vitreous is coming out. And I am totally unaware. I am just going to planning and implanting for IOL. I am taking, see there, I am taking the IOL, and by that time, see what happened. So with this video, I just want to emphasize that rule has to be followed. Rules are made to be followed. Even if the PC was intact, you have to fill it with the visco. Don't allow the chamber to collapse. Otherwise, see what has happened. So to conclude, this is a very good intraoperative checklist which was made by one of my friend, Dr. Kishore Mahajan. he has made this list and he has pasted it in the OT. Whenever there's a posterior polar cataract, he has asked his assistant that keep ready all these things before the starting of the case. So to conclude, identify before the surgery. What I mean by identify, that there is no any rocket science in identifying posterior polar cataract. But what I mean that suppose there are some young patients in which you get a white cataract, always think of it that it may be a posterior polar cataract which may turn into now a total cataract or white cataract. So especially in a young patient, if you see a white cataract, always check the other eye so that you can get a rough idea whether it is a posterior polar or not. And even though if you don't have any idea from other eye also, don't do hydro at any cost in young patients where the cataract is white. Large oval rhexis, no dissection, no rotation, very low parameter phaco. Avoid shallowing of the anterior chamber at all times. No PC polishing, no hydro implantation. In one of the case, I have done hydro implantation. Posterior polar case was managed very well, and as I had done the hydro implantation, whole the IOL was on the macula. Everything was gone inside the vitreous cavity. So no hydro implantation. Ensure optimum IOP while hydrating the wound. In one of the case, posterior polar case, while hydrating the wound, I have just hydrated side port a little bit and the posterior capsule gave away. So if you are in a doubt, if the incisions are, you are thinking that you need a more pressure, go for a Worm's pocket, but don't overhydrate or don't allow the chamber pressure to go, rather increase. So it is not like that posterior polar cataract is not manageable. Posterior polar cataracts are definitely manageable, but yes, there are definitely some rules or some guidelines that has to be followed, and that was my whole purpose of today's presentation. Thank you.
It's an absolutely beautiful presentation. What a pleasure to see you talk and you present that very wonderful presentation on PPC. And a couple of points which I found interesting is the concept of oval rhexis. Now I know that the oval rhexis concept is quite popular in the north, especially in Punjab. So if you can just tell our viewers about the concept of oval rhexis in PPC, please.
Yes, the biggest advantage of oval rhexis is we can manipulate in a straight direction, oval direction. We can make a big trench, we can divide, we can manipulate the nucleus, we can pull out of the back from in that larger median, oval shape, large side median. And suppose if something goes wrong, or like something rent happened, or anything goes wrong, then we can implant IOL horizontally where the diameter is less. And or otherwise we can do a capture also. But in oval rhexis, the biggest advantage is very much easy for this nucleus maneuver, and at the same time we can implant the IOL also if we require a sulcus.
Correct. Dr. Nikhil?
Yeah, I have seen, I have heard something similar from Dr. Abhay Vasavda, sir, where he was talking about PPC and oval rhexis. And the reason to make an oval rhexis is, it is not just to place the IOL horizontally if something goes wrong, but also to reduce the pressure when we are doing a hydrodelineation. By doing a oval rhexis, you are not directly putting the pressure on the weaker part, but you can just let the fluid come out of the extended part of the rhexis, like the oval side of the rhexis. That is one reason that we need to make the oval rhexis, actually, so that you don't really put you don't let the fluid directly go below the nucleus, but it can come from the other extended ends as well. So that would be another one benefit of doing a oval rhexis. So
point well taken. Although in my hands or in my practice, rather, I just go ahead with a normal standard circular rhexis rather than the oval rhexis. But I do understand the concept of oval rhexis, and I would encourage people to try it out and see what works best, either the circular or the oval. My only point in terms of circular rhexis is, if everything does go well, it has an excellent optic coverage, all 360 degrees, and that is what we would like ideally, right? So, but yes, I do understand the ovalization of the rexus has certain advantages on PPC. So that was one. I also saw in your video, Dr. Amit, about the side trenching without rotation of the nucleus. I think that is something quite unusual, because the degree at which it was absolutely 90 degrees at which you side trenched.
Yes,
Now,
yes, yes.
normally we don't get that good a trench 90 degrees to the primary one. I would rather, I mean, in generally what happens in my hands is I would trench it out and then make secondary trenches straddling the primary trench, but not completely 90 degrees to it. I mean, that's something which is quite, I would appreciate that, Dr. Amit. Yeah. So,
With the help of Ozil, we can easily make it. We have to keep the Ozil on, 100% Ozil power on, and with that Ozil, we can make that horizontal grooves also. And what was
fair
my
enough.
concept was to make that plus sign, horizontal groove, vertical groove, and just crack the nucleus from periphery towards center, but keep the central plaque as it is attached. So that if the cataract is slightly harder grade, we can get a 4 different pieces like a petals of flower which are attached in the
Correct.
centrally. And with the help of chopper, you can pull it one by one and easily emulsify. And in the last only, you can emulsify the basal.
Fair enough. So what generally happens in my hands is, after creating the primary trench and the secondary trenches, I'll be straddling, say, around anything between 30 to 60 degrees from the primary trench, not completely 90 degrees. And I would be, of course, without rotation, I'll be having two pieces of nuclei straddling the primary trench. Now, with my dialer going behind, I'll be trying to pick up those pieces. So I'll be having a gap in the distal end of the primary trench. And then moving on from there, I'll be trying to go ahead with a simple, if I have made a good hydro delineation where the nucleus is separate from the epinucleus, in that case, you can go ahead with the rotation of the endonucleus and then take it out. And then go ahead with the epinucleal management as you had described.
In
So
that
that is
case,
what usually happens.
the ball tip chopper is very helpful. If we have to go behind it and we have to just rotate the epinuclear sheet or like that rim, then in that case, that ball tip chopper comes very handy.
So
Very true.
what I do is I try, usually if I have emulsified one quadrant or one part of it, I'll just put some visco. I'll try to separate the remaining nucleus and try to get it in the center, rather than just rotating. And that is also quite it will just keep the nucleus, or we'll just get a feel that whether there is a dehiscence below, whether the posterior capsule is still intact or not, and we can just emulsify. And that ways we can keep our probe away from the posterior part as well. So the capsule. So that is another way, like putting the
Visco dissection
separating
works very well.
visco dissection.
Yeah.
Yes, yes.
Absolutely. So that is a good point. Another point was, of course, when we talk about PPC, we always talk about Dr. Bhayosada's inside-out hydro delineation. Has anyone tried it, and how does it work in your hands?
I've never actually. No.
Yeah. So I have tried it, of course, but again, not great success in my hands. I would rather go ahead with the traditional teaching, which I'm more comfortable with. But yes, the inside out is another technique of hydrodelineation in which the reported chances of PC dehiscence are reduced. Right. And any other point, Dr. Nikhil, which you may have?
So it's all been covered, actually. It's nicely covered.
Absolutely. So when encountering such situations, always we should be having a backup in any ophthalmic surgeon's armamentarium. We should have a backup of lenses. So we know that every time we are not going to implant a single piece IOL in the bag, especially in PPCs. So we should be very having ready about our multi-piece lenses, 3-piece lenses. And they do come in handy whenever we are placing it in the sulcus or we are doing an optic capture. I think they're the lenses to go in such situations.
Yeah.
Yes.
So, Dr. Sean, unfortunately, because of technical issues, he is not able to join us at this point of time. Otherwise, you would have loved his comments as well. But if there are no other comments, I would thank my speakers for having shared their valuable insights in these topics and their time. And definitely, I would feel the viewers of this Cataract Symposium, the West chapter, will benefit a great deal out of the topics which you have discussed and shown. Very good, simple points elucidated, and fantastic videos shown. So, thank you very much. I
Thank you.
guess that concludes our symposium 10 minutes ahead of schedule.
Yeah. Thank you. Thank you so much.
Thank you. Thank you. Thank you.
Right, and I thank the AIOS and Algren for putting together such a wonderful show for us, for our viewers. Thank you.
Thank you.